I'm Bill Kennedy with the Alabama Department of Public Health. Thank you for joining us today for our program, Ethical Issues in the Age of COVID-19, Part 1. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, dietitians, and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in as well, along with the sign-in sheet and the evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it is considered non-classroom hours. Before we get started, I'd like to introduce our presenter today, Jim Sacco. Jim has been with us several times in the last month or so. We've done 4 presentations earlier on COVID-19 and different groups of individuals, but today we're here to talk about ethics. So Jim's a consultant to the Alabama Department of Public Health. Welcome, Jim. I know you got a lot of information to present, so let's go ahead and get started with your presentation.
Great, Bill. Thank you. Thanks to everybody for making time this morning. When I was asked to do this series, part of what we talked about was coming around to the ethics of COVID-19. Obviously, it's a continuing education requirement for many of us, but also as I dug down into the content for today, and then we've got a follow-up 10 days from now, it struck me that there are some really interesting challenges that play out in the delivery of public health services and that affect our day-to-day life in public health. So I was really excited to kind of tackle this new program, and again, just grateful. What I always say is, with some of the ethical issues that come up in any topic, there's some of it that's black and white. The legal issues are black and white. There are, I think, codes of ethics that guide most social work nursing professions. Those are not black and white, but unfortunately, when you start to raise issues of ethical issues, I think it moves us into some gray area where we have to use our best judgment. We have to use our professional code of ethics as a yardstick, and then make our best ethical decisions based on what we consider good ethical practice. So I say that up front because there are some things that are not solvable that I'm going to present today, but I felt like if we didn't talk about them, we would be missing an important opportunity. So the course goal, and again, as I said, we're here today and we'll be here a week from Friday, same time, to do part 2. And as Bill and Rhonda, who helped design the program, and I talked, we felt like dividing the trainings into 2 parts made sense. And what emerged for me as I was designing the course was to think about macro issues today, sort of some of the bigger picture issues, structural issues, and then drilling down to some of the client service issues next time. And Bill and I were joking before we started, that's a little social work lingo for those of you who aren't social workers. Macro meaning kind of system, big sociological, big picture issues. Micro meaning the client relationship and our interactions. And one of the things about our social work beliefs, social workers, we heard this should have heard this the first day of social work school. We view the person in their environment, the sort of social, interpersonal, cultural, and in today's topic, sort of environmental, cultural, and political environment. I want to say up front that it's impossible to kind of bring up these big picture issues without just at least naming the politicization of the response to COVID-19 and how divisive our reactions have been. I am not advocating any political belief system or any party or any political figures. I am just laying out for all of us that this public health question, which is really, I'm a public health person. This is really a public health conversation, but you can't, it's impossible at the macro level or with our clients to divorce the public health response and public health challenges from the political reality. So again, we're not interested in a political debate. I'm not offering a political talk. I'm talking about public health issues and how, as public health professionals, we respond. So those are our outcomes here. Ethical issues. We're going to talk a bit at the end about working remotely. I know, having talked about that, many ADPH staff have gone home, and sort of what goes along with being a remote worker. It was also really interesting as I prepared this to kind of think about what's happening to the workforce as people have moved home, and which of those changes, and then some interesting things about who didn't move home and what the implications of that are. And then next time we're going to touch on issues in digital communication. We'll do more of that next time at the macro level. So as Bill said, we've done a series of these this summer, I think 2 in June and 2 in July. I start just not to make this a surveillance talk, but I think, again, as we're sort of addressing any topic related to COVID-19, I think giving us the surveillance data, helps ground us in kind of what's going on in terms of the pandemic. As I was getting ready to do this talk today, I was pulling my surveillance data Monday, and I had another talk up from July, the first week of July, when I did a talk. And what struck me was the contrast between where we were July 1 and where we were on Monday. And I think certainly in terms of prevalence, illness, impact of the disease, I think it's been a very bad 33 days, more than 2 million new cases in the month of July. If there's some good news, I think it's that we are better at treatment for COVID-19. The rates of people dying from COVID have continued to decline as medicine healthcare has gotten savvier about how to keep people alive from COVID. So yeah, those are the numbers as of Monday. 4.6 million Americans, and again, 2 million more cases than a month ago. Increasing cases, this looks pretty similar to the talks I've been doing. Unfortunately, much of the Southeast continues to lead the way. What tends to have happened is that states that were earlier, and generally states that were earlier and more aggressive to open up, more reluctant to mandate mask use, have been more problematic. It's not exclusively true, but that pattern tends to be there. And then cases, what I did is the Kaiser Family Foundation does rankings, case rates by increase, and I just kind of sort by increase over the last 30 days, and these are the findings. And the lower case rates, mostly in the northeastern United States, again, mostly places that were longer to keep people at home, more restrictive in terms of movement, slower to open up, and more stringent about mask use. And so there we are, and unfortunately, this pattern continues. What I'd highlight, although the actual case increases are not showing up, there's talk of a number of Midwest states experiencing an increase. Again, I think these few success stories down at the bottom, these 5 or 6, 6, 7 northeastern states, are about the only bright spot. If you look at a surveillance map, sort of where the red counties are, where the red states are, 3/4 of the country is moving in the wrong direction. So, what's not new and what's new, I think what we've seen is a real pullback on this sort of get out and open up. I just want to acknowledge that the tension of opening up, that I'm glad I'm not the governor of nothing, because it's really a very difficult set of decisions. There's, on the one hand, the economic cost. I'll talk about this in just a minute. The economic cost of closing businesses and keeping people at home, and the reality of human nature. Part of what I talked about in one of the July webinars is partly this is just people's fight or flight, being locked up response, and the normal human desire to get out of the house. I've had days where I just think, if I don't get out of this house, I'm going to scratch my eyes out of my head. So there is kind of human nature and the economic concerns, but as Florida, Alabama, Mississippi, I've seen this increasing in case rates, alarming increases, the sort of pulling back, no, we will close restaurants. I think restaurant openings is central, mandating mask wearing, restricting the number of people who can safely come together, like that shift is we've sort of gone back in a number of the southeastern states. Again, better survival rates. Again, people early on, we had so few medical interventions and knew so little about the course of treatment. The other kind of fly in the soup to consider is it seems like every few days there's a story of long-term medical consequences of COVID infection, even mild cases, respiratory complications, some neurological stuff that seems to linger. And so, what we don't know is I have a buddy that had a mild case early on, and so you kind of go, well, great, he dodged a bullet, and yet he's had some weird neurological stuff, nothing life-threatening, but even, weeks and weeks after the disease resolved, this mild case resolved, he's got some lingering stuff. And so, again, because the pathogen is new, we aren't sure what's going to happen. So good news, bad news on the medical front, better treatment, and sort of what are the long-term medical complications around the world. Again, not to make this totally a surveillance update, but Brazil, India, Russia, there's the India twice story, and Mexico, places that are experiencing the highest rates of growth. And particularly alarming, I hadn't seen until I was preparing this talk last week, that all the countries around Brazil, South America, is in very bad shape. And unfortunately, Brazil was very slow to respond, very slow to lock down, resistant to mask wearing. Again, that pattern of not taking stay-at-home orders seriously, not taking the virus seriously, not mandating social distancing and masks. In Brazil, cases are off the chart. And because of, like the States, how fluid travel is, all the countries surrounding Brazil have had serious outbreaks all around, much of South America. And then, on the domestic front, this decision about opening schools, and shall we have baseball? Can we have football? Bill is chomping at the bit for the Crimson Tide to be out there on the field, and I'm not putting money one way or the other. Are we going to see the Crimson Tide out there this year? And then again, just to name the elephant in the room, the continued kind of political divide. And in some ways, I guess it's not surprising given the political divide in the country, but I think the schism of our side and their side, or your side and my side, and issues about all the public health issues. Should we open schools? When is it safe for sports to be played? What are the prevention measures? That much of that is now viewed through the lens of, are you on this side or that side? Are you a liberal or are you conservative? And again, from part of why it's so troubling to me is this a public health issue. Like, how do we keep people alive? How do we keep people from getting disease? How do we control the spread of the disease? But it's taken off. So there's a reminder. That's the end of the brief surveillance update. That's a reminder about the email. Bill is monitoring that. I'll check in several times during the course of today. Also, the phone number that you've had earlier. And then I understand a number of people are on Facebook Live, and you can ask questions through Facebook Live and feed those in. Again, I've asked Bill to sort of weed out the political rah, I'm on this side or that side. This is a public health talk. There are places for a political rally. I just don't think it's helpful to all of us as public health professionals to spend too much time on my side or your side. I'm really trying to focus on the ethics of this public health response. So anyway, so macro issues. I said we were going to start, and again, it's not intended to take us down a road, but I do think if you just think, I know a number of my Alabama social workers have gone home and now are doing contact tracing, and so people are working in the field with people with COVID, seeing people in the clinic who have COVID-19 or worried about COVID-19. I just think you can't divorce people's testing and screening people for COVID-19. I think it's just really hard to divorce what's going on that phone call doing contact tracing or in that parking lot. Seems like most of our testing is in tents or parking lots from these large social issues. And so again, what I intended to do was kind of say, as you prepare to do testing, do contact tracing, do case management, my dietitian's doing good nutrition planning and diabetes management, that through the lens of what's going on in terms of the big picture, our conversations about COVID are inherently through the lens of these larger system issues. So anyway, how COVID is respiratory droplets. The worst is cough or sneezing, the more sort of forceful way of getting those droplets out in the world. Also, some studies about singing. Bill can't wait for the choir to fire back up at his church, and we've got that study, the case in Seattle. And it's another one I can't remember. The Seattle case, 85% of the choir got COVID. Somebody was ill and asymptomatic, and they were just singing it out, and because they think of this exposure in choir practice. And so what we know is respiratory droplets, worse indoors, worse again with the force of coughing or sneezing. There's people that are concerned about opening up gyms. Again, I'd love to get back to the gym and start working on this COVID-19 that I'm carrying around. Or if it isn't 19 yet, I'm moving in the wrong direction. But as people are working out, those respiratory droplets on whatever make transmission more likely. So through my eyes, my nose, my mouth, sort of avoiding touching our faces. The good news in terms of transmission is surface contamination isn't nearly as effective as respiratory droplets. And indoors is way riskier than outdoors. So again, if I were to bring some good news as people, there are a number of websites that are ranking risk. And so it just looks like being outdoors is not as risky. So we're doing some socializing outdoors with people. We sort of finally breaking out of our bubble. We're not having people in the house, and I sure don't want to go to the gym, and I'm not ready to go back to choir practice, but outdoors where there's airflow, there's just less transmission of these respiratory droplets. Once I contract COVID, it's deep in my lungs. It's a respiratory infection and all sorts of, again, from minor fever in many people, body ache, sort of flu-like stuff, some weird loss of neurological stuff, including loss of taste and smell, happening with a fair number of people. But the achy respiratory stuff, the sort of severe lung disease, tends to be the most common presentation. And so, again, you've run in those droplets or you touch your nose, and anyway, and you don't have your mask on, you're the person who's infected. doesn't have their mask on into your body, affecting your respiratory, but also organ damage. And for people that get severely ill, it's respiratory, but it's also other systems of the body, again, including neurological, lots of neurological stuff. So, the what I would call this the COVID unupdate. This is the non-update. This is like what we're supposed to do. The guidance is clear. Probably mask wearing and physical distancing are the most important things. Again, 6 feet from other people, wearing a mask, hand washing regularly. I suspect everybody, if you can find sanitizer, I'm reaching here because it's right here in below my glove box. I just sort of get in the car and reach right for the hand sanitizer. I'm sure I'm not the only one who, if I'm out in public, I'm going to be a hand sanitizer the first chance I can. So regular hand washing, physical, these are the ways. And then isolation when someone's possibly been exposed. That if someone's had an exposure, staying really in a room, having meals left at the door, like super cautious for 14 days after possible exposure. A friend just talked about a work colleague where the whole family got sick. The whole family contracted COVID. Mama got the worst case of it. Everybody else starting to recover, and she's not. She's still at home, but what they've said is because they're not sure about immunity for these folks. If she's not better soon, they're going to put her in isolation so that she doesn't reinfect the family members who've already gotten. There's real debate about how long. It's certainly starting to seem like you're not immune forever from COVID-19 reinfection. And there's some people that think immunity may last very briefly. And so anyway, the self-isolating, you think of when someone who's been exposed comes into a family that hasn't been exposed or a home they share with people. But given it 14 minutes, Bill, you got a question?
Well, Jim, I was just going to jump in and say that on our 8:30 call this morning, we literally talked about how really the guidance hasn't changed as far as how to prevent this virus from spreading. Hand washing, distancing, mask, self-isolation. Lots of things have changed as we've learned more about the virus over the last 4, 5, 6 months, but these 4 basic things have continued to be the same thing, the same guidance. And certainly we had a big discussion here yesterday related to schools and a toolkit, and a lot of that covered these 4 things. And I think the biggest eye-opener was self-isolation. If somebody in the classroom is positive, who's going home and how long, and but we know that's what's going to happen is you're going to have to start sending people home to isolate it, to prevent it from spreading even further. And certainly nothing new there over the years with our I remember the chicken pox back in the day.
It's good infection. It's good infection control, really.
Correct. And influenza, and so all of these are just great things to remember and to practice. And so I think we've covered this in every single presentation, but it's important to continue to repeat.
It's the unupdate. And yet, Bill, I bring it back because, issues of distancing and isolation and mask have taken on kind of been part of the political fight.
Right.
As it relates to schools, I'm going to get there in a minute, but as it relates to schools, I just saw a photograph this morning in a newspaper of the first day of high school up in North Georgia. Kids just being high school kids in a packed hallway, maybe 10% mask. Everybody else, how was your summer, and hugging on each other, whatever else. And so even as we try to figure out safe school reopening, kind of what's the percent of kids who are going to physical distance, what's mask use, and what are the issues for teachers? So as we start to talk about, how we're going to prevent, I don't want this to be an academic, long drawn out discussion about the history, but I want to put this in context. Many of us have heard about the big flu of 1917 and what happened, probably the worst, I think one of the worst pandemic flus in our country's history. But what I went back to, I just sort of did some research, like, well, where do communicable disease laws come from? Like, what I know, being a certain age, is, probably the first time it came about for me was STDs and HIV and TB, and that as a public health system, we say, gosh, if you got TB, we're gonna make you stay home, and we're gonna isolate you, and we will directly observe your therapy. We're gonna make you take your TB meds. And again, so that's my 30 years of public health experience. If you've got STD, we're going to grab you. We're going to notify your partners. We're going to sanction you if you're not doing the right thing. We're going to, make sure you take your antibiotics. If you've got HIV, same thing. Laws that protect people, you're required to notify your partner. So that's my, history of the last 30 years of my public health work. Well, let's go back to 1647. I mean, so really, as I was looking at this, is a paper from Harvard. And again, I'm going to do this quickly. I promise. I don't want us to go down this road because there's much more current stuff. But the history of, even in Cologne, before there was an America, sort of who can come in. There was a outbreak in Barbados, and a ship from Barbados came, and we turned them away with sugar back in the day. Before there was a United States, we started to figure out who letting people in or not letting people in as a way to control disease. So late 18th century, 19th century, cholera, yellow fever, kept coming back to plague, cholera, yellow fever in terms of our country's history. Certainly the 19th century. But even then, as I went back to this history article, even then it was Boston saying, here are our regulations, and the colony of Massachusetts, or eventually the state of Massachusetts, saying, no, we want to be in charge. And so what struck me as the mayor of Montgomery argues with the governor, I don't know who's arguing. I don't even care who's arguing, but whoever's arguing, governor of Georgia suing a number of mayors in the state of Georgia who wanted more restrictive. This goes back to the 1800s, where even again, cities wanted one thing and states wanted the other. So there's an international conference in the mid 1800s. U.S. conference starts in 1905, and really this kind of modern public health containment sort of goes back to these early meetings, sort of first conference ever notifying people, how to notify people. Again, those of you doing contact tracing for COVID, we look back to the early 1920s and following up cholera, plague, typhoid, and letting people know across jurisdictions, informing people if they'd been exposed. And then again, as we look at current public health practice and public health laws, real seminal part of that is the 1944 Public Health Service Act, where the Surgeon General has responsibility to prevent introduction and spread of communicable diseases from foreign nations, or from one state to the other. And so it's the role of the Surgeon General to keep us safe. The Surgeon General has the capacity to limit travel, limit restriction, do whatever in his or her, mostly it's been his, but we've had hers. I was trying to think of what's his or her response to keep the American public safe. That role falls to the Surgeon General. So bringing it back to COVID-19, thanks for indulging me with a little history. March 13th, we've got an emergency declared. Most people start to say shelter at home, and that really weird time in late March where I think everywhere in my town, I live in Asheville, North Carolina, 10% of the typical traffic. I mean, just really bizarre sort of what shut down felt like in those early days as we in North Carolina sheltered at home. Most places, all states by the end of March were on some kind of don't travel outside your home, except those 8 states that, for prevalence reasons, for some of them, I think, political reasons, and some folks said it's not a problem here. Wyoming, we're so spread out, we have so few cases. Again, as I was sort of trying to get a timeline together, so that's late March, 42 states are locked down. By late April, Fortune magazine article that already starts to say, well, it's time to reopen. That the conversation about let's reopen and again how to do that and when to do that. But we were barely home for a month, and again, there are people that contrast us to other places that did a better job at lowering the curve. And again, I'm just talking about public health response here. But what happened most of Western Europe was people were at home 2 or 3 months. That in terms of flattening, that response, like a more concerted effort to stay home longer, probably would have us in it. Well, surely, I'm going to go out and surely would have us in a different place today. And critics say this early conversation of it's time to reopen. So here's the argument. Here's what was going on. 22 million people out of work that first month. And so again, it wasn't people being cavalier, but this ethical question I raised here: how do we control the disease? How do we control the spread of COVID-19 and acknowledge the economic pain to millions and millions of people? 22 million people that first 4 weeks, were 32 million now. Some people weren't getting their stimulus money yet. The paycheck protection ran out of money. So just these sort of dire economic times, people weren't spending money. I certainly have done my part with a little online shopping, but I look at my debit card for the month of March and April and how long a tank of gas lasts. I mean, it's unbelievable how long a tank of gas can last because I'm not going anywhere. I live, work from home and whatever else. And so, but what that means practically is my guy at my gas station used to see me once a week. He's seeing me once a month. And so for the Shell station down the hill from me, what he's seeing is a 75% reduction in business from me and likely lots of the rest of us. And then the stock market decline that started in second week, it was 18th of March, I think, is when the stock market hit the skid. So all this economic stuff is going on. So we've got people that went home, did the right thing. And this tension, partly because of the economic pain people were feeling, individuals and businesses in real economic pain. And then in April, we started to have this conversation about individual liberty. And what I say here is, the first thing I learned in probably grade school or either junior high school history, I don't know when they teach probably grade school history, is give us our freedom is what America was founded on. We were tired of the British telling us, we were British colony. We said, give freedom or death. And so this whole idea of freedom and liberty and the value of individual freedoms is baked into our nation's fabric and who we are. And so freedom to assemble and worship, we can bear arms. These are in the Constitution of the United States, all these things. And here comes a pandemic and a public health response that says, no, you're not free to assemble. No, if there's more than 10 people inside a place and you're not 6 feet apart, you're not free to worship. And I think your right to bear arms continues, but there have been, I think, I'm going to go on a limb, at least the last 12 years, maybe longer, a growing concern among some people about government overreach. That the perception of government as being too intrusive in our lives, overtaxing us, rushing to vaccines that aren't safe, trying to steal our firearms, taking eminent domain over land. And so for a significant percent of Americans, all of these kind of wear your mask and stay 10 feet apart, and you can't go to church and you can't go to the club or the lake or water ski or whatever you want to do, come through the lens of kind of, I think, have triggered something for people who sort of have had an idea of government as being too involved in their lives and violating personal freedom. So what we see by late April is organized protests, the people at state houses, North Carolina. I will call out my own state. We had people, Michigan, several state house organized protests that COVID might not be real. Again, that to me is a corollary to the vaccine safety movement. Like, can you trust the scientists, and are the scientists and medical establishment in bed with the U.S. government, and is the CDC trustworthy? So COVID skepticism, anger, and then again, concern for the economic impact, and I believe just a desire to go out and have a drink. I mean, you know what? At some point, I get it. It's like I was so exhausted in April when all this started. I thought, yeah, I just didn't go out and get drunk too. Sorry to be so frank, but it makes sense that people were tired of this. They wanted to go meet their friends. Again, several stories in March or in May, and then certainly as we get closer to Memorial Day, people just being exhausted from COVID. Beaches open up, businesses start to open up, and unfortunately, what we saw was increase. I call it fatigue in reaction to the distancing and mask requirements. One of the talks I did this summer, I talked about the fight or flight response, and that it's our neurological system that you know, I feel it. I mean, I remember my first few times venturing out to a grocery store, either a hardware store, just like, who's got their mask and will I be safe and what could happen? This was when, you know, early on you were afraid to touch an apple at the store had someone else touched it, and so partly again, it's just the neurology of a neurological system that's been on alert, just wanting to relax and wind down. So part of what emerged was not all this government overreach, but also just kind of, oh my gosh, I'm just so tired, so I'm going to go out. You know, we saw pictures on Memorial Day of people boating and, you know, wanting to get back to their life, you know, which I think is human nature, and unfortunately in some cases resulted in disease transmission. Mask requirements sort of becoming a liberal versus conservative dilemma. You know, again, as Bill said, the same four. I've had that slide for every talk since we came here in June. If I'd done one in May, it would have been the same slide. The talking points to prevent COVID-19 remain the same, but again, it became viewed as aren't you liberal or conservative, and it became the issue of mask wearing got to be part of a political divide. And then again, this merging of skepticism about COVID and anti-government feeling, and mask wearing becomes skeptical. I mean, I think you know, my own experience is I go on occasions when I go out to a store, to a something, 80% of people are wearing a mask and doing whatever else, but there's a percent of people who are not, and I don't know what those people are thinking, but I think as we look at issues around wearing masks or not, that these kind of socio-cultural, socio-political factors influence whether or not somebody puts their mask on at the grocery store, what they feel about mask wearing, and often how they feel about requirements. We've seen a number of blow-ups online. I've seen a number of scenes online where someone gets mad because they're required to wear a mask. Bill, let me catch my breath. Are there questions yet, or any comment you've seen on email or the Facebook?
no questions yet. I do have a couple of notes I made, and I'm the son of a history teacher, and so I appreciate the history lesson there. And
thank you. You may be the only one, Bill, but I'm glad somebody did.
I may be. Couple of things that came to mind. I made some notes back. I got to tour Ellis Island a few years ago when I was in New York, and some of the big. I just remember from that tour how they isolated and quarantined folks and would not let them into the country if they were, showing any signs and symptoms, trying to prevent that from getting into New York City and us into the country as well. And also do a little genealogy. We were talking before, and as I've looked back through old newspapers and doing some research, they used to advertise in the paper, in the local newspaper, the county health officer is quarantining a group that's coming in from somewhere for smallpox or, something else that was going on in the area at the time. And so, and also I found some relatives that had passed away in their early 30s back in 1918 from the influenza outbreak there. And so certainly that history is gone for years and years. I mean, really probably since the beginning of time, if you think about it. And my wife is a school teacher, and she teaches a unit on Native Americans. And she talks about how, when the Europeans came to North America, I bet the Native Americans at the time wished maybe we had quarantined before we came in, because
there are diseases we brought that weren't here before, I think,
and they didn't have the immunity to them. So certainly, I appreciate the history lesson there. Yes, I am ready for Alabama football to get started.
I know you are.
Another comment. And I've enjoyed watching the Major League Baseball.
Yeah, which I think you better tape it, Bill, because I think that's winding down, unfortunately. Well, let's talk to your wife, Bill. Let's help your wife out here. Let's open them schools up, shall we? So one of the important, again, big picture debates we got going on is what to do about schools. And Bill, I know you were involved in working with ADPH on how to do this. Most schools, we left the building, started distance-based parent instruction, some combination of trying to get kids to sit in front of Zoom and parents becoming teachers. I think consensus among everybody. Here's the argument, Bill. I know this has been the last few weeks of your life. I think everybody agrees that instructor-led learning is superior. That there's no question that having a teacher at the front of the room makes sense from an educational perspective. There's a real push to open schools because how that helps the economy. Again, the thinking that kids going back to school gonna join commerce and or mama can go back to work and whatever else. And in this balancing act, teachers are saying, what about us? That as we think about how to reopen safely, the vulnerability of teachers, what we know is, trying to think of the language, the symptoms of COVID-19 appear to be much less serious in young people, children and adults. However, they do contract, children, adolescents, young adults do contract COVID-19, again, most commonly with fairly minor symptoms, but the ability to transmit that COVID, even as they're asymptomatic, to other people, their parents, their teachers. And so part of what I'm sure Bill has been wrestling with, anybody who's in a school setting is wrestling with, is how do we keep kids healthy, and then those kids are in a room with teachers, some of whom bring some vulnerability because of age or pre-existing medical, and their parents and their grandparents. So this kind of concern that we gloss over and we say, oh, kids don't really get that sick, negates the teacher in the room, and I would argue negate that they go home to a family and then they go home to grandma and grandpa and hug on grandma and grandpa. And so Bill and I were talking before we started, these outbreaks of COVID in stay-away camps, North Georgia. He said it was another one in Mississippi. Are just instructive how contagious this thing is once COVID takes root in a place where the North Georgia one in particular, kids were not required to wear masks. The instructors were wearing, the camp counselors were wearing masks. And I think it was like 50% over the course of 7 or 8 days. It's 50% prevalence among the young people at this camp in North Georgia. And you multiply that times every school. And then you have to think about teachers and grandmas and grandpas. And so I want to, just sort of planting those civil liberties debates. And I want to talk about what's happened as people have gone home. Bill was talking before about the percent of the ADPH workforce that's gone home. I know many public health departments are still mostly working remotely. There was a movement. Part of what I did in preparing for this was sort of look at where we were before COVID. There had already been a significant increase. An article that I reviewed talked about 159% increase in who works remotely between 05 and 18. So turn of the millennium really saw an increase in terms of working remotely. I mean, think about it. I've been in the workforce a long, I'm just going to give a number. I'm just going to say a long time. 20 years ago, nobody would have said, oh, it's my telework day, or I'm working from home these days or that days. I mean, it just didn't come up. Every once in a while, my experience with salespeople would, they were on the road so much that they didn't even have an office, some of the salespeople, but increasingly, just sort of it's my telework day, or I'll be working from home that day, or catch me on my cell phone because I'm not in my office. People whose signature line says telework Monday and Wednesday, or whatever their days are. And yet 40% of the workforce never, ever work remotely. And almost 20% were full-time at home. This number surprised me. That was higher than I would have thought. Again, most of my friends, most people I know, do a day a week or two, or have some flexibility to go home. But nearly 1 in 5 work remotely all the time before COVID ever happened, and a whole bunch of people worked once a week. Fast forward to March 18th. Seems like March 18th was the day everybody came home. Some folks, it was March 25th, but whatever it was the end of March. 42% of the workforce. As of June, 42% as of June were working exclusively from home. And what's interesting about this is that represents more than 2/3 of our economic activity. So what that means is where they work and how much they're paid. And so the movement of the workforce has not only been more people at home, but generally more professional, higher paid parts of the workforce in certain industries, white collar industries, are the people who gravitated home. And what that means is a higher than average percent of the workforce has gone home and taken their work with them. About 1/3 of us not working, 1/3 of the workforce is still not working. I think I just read something yesterday that said 32% out of work, and 26% are going to work. About 1 in 4 people who are reporting who are deemed essential, and sort of what that means to be essential. And again, as I looked at this, I just started to think about the ethical issues of the divide, as it were, between who's at home and who's not, and maybe even some stigma about who's at home or not. People want to work from home, at least partially. Part of what is emerging, I read a Fortune magazine article. Fortune magazine last month interviewed CEOs, and there was a number of CEOs, maybe a dozen, 15 CEOs. There was just general consensus that it's probably not going to look the same as pre-COVID, that more people want to be at home. A third say, I don't ever want to go back in an office. I have made my living for 20, 25 years in the basement of public health departments, or in a conference room in a Marriott hotel or something, doing mostly in-person training, and I haven't been in a training room since March. And I kind of think, even if people go back, a third of you are saying, I ain't going back if I don't have to. Even if people go back, I think the time when people are going to come together for in-person training, I've said half jokingly, the days of a 300-person conference with lots of people breathing on each other and sharing donuts and whatever else. I cannot imagine a medical public health conference happening in person with everybody over the same plate of donuts for a very long time, my hunch. About half of employers say they're going to keep their people at home. And so, so what's that going to look like for us in public health? What's it going to look like, certainly as we provide services? Just, I remember how foreign doing a Zoom call was maybe a year or two ago. Like, what do you mean? Why just pick up the phone? Or, I'd done some webinars, but the idea you'd have a virtual meeting, now it's just, Zoom me, Skype me. Somebody I work with has Microsoft Teams. I got to go into that. So all these platforms. And so what does it mean in terms of our day-to-day lives in public health, in terms of the work lives of people who are our clients? Part of what we're all struggling with, now I'm speaking to people with small children, is you can't have children at home and no teacher unless you're rich enough to have a nanny. And I pray people in public health have a trust fund so they can buy a nanny, but most people are juggling kind of, how am I going to get this report in? How am I going to be on that call and keep my kids learning? It's been a hard spring for my people with small children. I'm going to send out a shout out. If you kept your family alive and kept food on the table and kept employment with small children, I'm going to call you out as being a hero, because it's been a tough spring for people that work from home with children and not having a school to fall back on. And again, the exorbitant cost of childcare just makes it impossible. So many of my friends are just juggling, plug them into something on the screen and try to do that call, try to get that report done while you making lunch and keeping them entertained. So as we talk about this, sort of the challenge to the workplace is, how do you make work more flexible? I'll give you my 8, but I can't do 8:30 to 5 like I used to, because we're not in school. I don't have the daycare's arrangement that I used to have. So many daycares closed or became cost prohibitive or limited how much daycare. We're going to need better hardware and equipment. Bill and I talked about Alabama shutdown and how people didn't have all the technology they need. My sister works for the state health department in North Carolina. She had 2 laptops for an office of 12 people. Everybody got sent home, and she's like, who's got 10 fired up laptops ready to go that I get to my people? And she's in one of 12 or 14 offices around the state doing the same thing. And everybody had, for those emergencies or infrequent work from home days, a few laptops that they shared. No idea they were going to send the whole workforce home with a week's notice. So, trying to figure out when staff must be available versus when I can tend to my family or do whatever else. And I just want to say, I don't think most people are goofing off. I mean, I think people are giving their all, but just, again, families with kids are struggling to figure out. My neighbors across the way, 2 working parents, both pretty demanding workplaces that have been, expecting them to stay on their game, and 5-year-old twins, both parents in pretty demanding jobs. I mean, it's a lot. And then that last bullet there, sort of work-life balance, how people going to keep their kids alive and keep their job going, whatever else. So, as I said, there are issues about who's not gone home. And again, I think certainly that's healthcare. We've kept some healthcare providers at work, frontline healthcare providers, retail people, hospitality, transportation, things that were deemed essential. And again, I'm grateful. I'm grateful that someone's there to sell me groceries. I'm grateful that someone's kept my gas station open through all this. And part of what feels important to name is that disproportionately has meant more women, people of color, and lower wage earners are not working from home. And as I gave that statistic earlier, 42% of us equaling 2/3 of economic activity, that's about wages. And it's about the industries we work in, but it's also about wages. And so there's this kind of divide between who's home and who's not. And I don't have an answer, but I just want to name, as you sort of have conversations with client provide services, especially if you are someone who's not going into the office, if you're not in clinic, or if you're not in the office and you're working with people who are still punching a clock, are still expected to show up. This bigger picture just kind of, the last bullet just kind of raises the question, what happens to people who are essential workers? And again, certainly in healthcare, I think the opportunity to have training and other opportunities, but I look at people in the services industry, in hospitality, in retail, and I think, I'd like to believe that the opportunity for the 25-year-old pharmacy tech at the front of my pharmacy. I almost named my pharmacy a national pharmacy. I hope that she has the same opportunity all of us hope for and want, but I wonder in this day and age that if going to work and punching the clock and whatever else might impact her ability to move forward and advance, and what the implications are for people who are essential and what opportunities don't exist. So not news to most of us here in public health, but part of what has been the underbelly for how difficult it has been for our public health system to respond is just the absence of public health investment that the culture's made, that of every healthcare dollar, 3 cents goes to public health and the rest goes to insurance and CAT scan machines and blah, 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 and that what's left is 3 cents on every dollar that helps fight disease, track disease, fund all of us. I didn't realize how many public health jobs were lost in the reception of 2008, but 50,000 jobs. I know most places I go, there's a story of, yeah, there were 3 of us in the department, now there's 2, yeah, there were 4 of us, now it's 3 of us, whatever, but I didn't really make the connect, but a whole bunch of public health people left. Significant decreases over the last 8 to 10 years in preparedness funding, and certainly that has, and then this concern, I just want to name it, of bloated bureaucracies and them government workers just being government workers. I mean, if you are a public health employee, you've had a brother-in-law or somebody get drunk and talk about, yeah, I wish I didn't have to work because I work for a bureaucracy. And so sort of as we go into this, you want to say, well, no, a decrease in public health funding is part of why we're struggling to get laboratory up and running, get tests, get enough contact tracers. But then this tension of, well, is there too much government? Are public health systems efficient? All that has clouded the debate about a public health infrastructure that most smart public health people would say just wasn't efficient before, wasn't sufficient before there was a COVID-19, and isn't sufficient moving forward. Bill, what do you think?
I got a couple of comments that have come in. The first one says, it's from Marcia. She says she really enjoyed the history also. So there's a couple of us out there.
Good. History nerds, you go.
Yeah. And she said, she just sees the government is trying to keep us alive as we try to figure all this out. And, and that goes back to even when we were early, a young country. So, and then Sonia, she said, yes, it's just been really difficult to adjust working remotely with young children and a family. And so,
man. Yeah. And Sonia, I'm telling you, I feel it. Like I said, I've got friends that are trying to do it. One of my girlfriends is a single mom of a 6-year-old and again, trying to pay the rent. I think schools are trying to be understanding. I think employers are trying to be understanding, but man, oh man, when you think about the long haul, my fear, Bill, I'm going to go on record, is that schools aren't going to stay open long, that I hope I'm wrong. I hope we can keep everybody healthy. But my fear is just once people go back to school and kids get sick and in enough numbers that there'll be a backlash and people say we're going to pull back and go virtual or partly virtual, and then parents are back in the same boat of over the long haul, how do I do my job and be a teacher?
And I know that's one of the things that we on our calls here that I hear from our administrators are, we've had to send more people home because they've either come in contact or they are sick. And so, how do you staff? How do you provide the services that need to be provided? I think you're fixing to throw in a new curveball in that we've had kids at home, but now you're going to get the call from the school, hey, you've got your son, your daughter's come into contact with somebody and they need to go quarantine for 14 days, or they are going to become sick, start showing signs, and so they need to isolate. One other comment that came in, we're seeing a lot of retirements, and I read an article this past week about the brain drain that's happening across the country with individuals that said, I've had enough. I think I'm going to go to the house. I can retire. I was going to hold on for another year or two, but I'm just not going to deal with this, or maybe I don't feel comfortable going back to the workplace. Or don't want to learn, this new technology or whatever it is that maybe they're having to do. Some that are being put into positions, this is not what my job was. They are asking me to do something totally different because of the need.
Yeah. No, you're right, Bill. That was already coming. I mean, I was at a meeting a few years ago where somebody said, I can't remember, 3 or 4 years ago, but somebody said like 25% of the public health, 25% of the public health workforce was ready or about to retire. I mean, like that's been coming. Look at our friends, Bill. You know what I'm talking about. I'm not going to name names, but people that got their years in. We don't dare name names, but got their years in, and and have just been weighing the pros and cons and am I ready or not? And so. Both sort of asked to do a new job and Bill, let's name it, fear of contagion. If I'm in a county health department and particularly if I'm expected to be there on the front line, I mean, I could make a case somebody in their 60s on the front line that's got their years in to say, you know what, both a number of things come together, but I think fear of contagion. And I guess, Bill, I'll just end the school argument with the question that we don't know is what parents' tolerance is going to be for letting their kids be in a school where COVID has happened. And are parents going to be able to say, well, there's only a couple cases, I'm going to hang in there? And I don't have the answer, but I think part of what's yet to be determined is sort of our parents going to be able to say, well, they've got some cases, but they're managing, and we're going to keep sending Brittany to school, even though we know there's prevalence of COVID. COVID has already happened. And I guess my guess earlier was that I'm thinking parents are going to have a pretty low threshold for continuing in-person instruction once cases of prevalence of COVID emerges. So last thing I want to do is just talk about...
One more thing, Jim.
Yeah.
One more thing.
Sure.
It just hit me. So certainly here in the health care profession, we've had a lot of folks that have, had to stay home or whatever because of contact. Now you've got teachers. And so who do you find to substitute teach? Those kinds of questions. Who's going to fill in? And do you have somebody for 2 weeks as they're sitting home for 14 days? Those lots of crazy questions that we never thought we would have to worry with, and here we are.
Yeah. Well, and you raised the issue of public health workforce. You can't tell me that some of your wife's colleagues who almost had their years in aren't saying, do I want to go back in the classroom? I've not read it, but it's hard for me to imagine that we haven't seen and won't continue to see a fairly significant exodus from education, I would think. Again, those teachers who were close, just kind of saying, now I got to teach through a plastic mask, or I got to distance, or I got to jump back and forth, distance and not. You can't tell me that some of those folks are not going to say, I've done my 32 years and I was holding on for my last 2 or whatever, aren't going to say enough. Last thing I want to do is just kind of talk about providing health care and other health services in the age of COVID-19. So for those of us in public health who are doing this, in many ways, what's important is telehealth and working remotely isn't not new. It might be new to your job, but we've had telehealth around, particularly in rural areas, for a long time. I'm trained as a clinical social worker, so a lot of how I view the world is through the mental health lens. Well, you can't find a psychiatrist in most counties in the United States. You can't find a psychiatrist, and often a psychiatrist is 40, 50 miles away from any public health department or any health care. So you've got all kinds of places where the psychiatrist has always done visits virtually, other subspecialty. I'm thinking, rural Alabama, much of my view of the world is the rural Southeast where I mostly work, but rural Eastern North Carolina, places where they just aren't neurologists, endocrinologists, whatever. They're just federally qualified health centers have been plugging people in front of telehealth. So that's been there a while. We've had patient portals. I mean, go online and see your results. That boomed, I want to say 8-10 years ago. You logged in to check your own lab results. So all that's been happening, but the pace of moving to remote work, the pace in which we've gone to telework, is really unprecedented and something that has changed all of us. And again, what changes will be permanent. So certainly screening people with COVID. Early on, the first email I got from my healthcare providers is, we're happy to talk about your physical symptoms of COVID, and you will log into a thing, and we'll do that virtually. My practice was very conservative in terms of not having people, and they wanted all that screening to be whatever platform, I think Zoom, but I don't even remember what they were doing. Trying to screen people with, flu or things that weren't COVID, backache, and trying to keep those low risk urgent care somewhere else. Like, people early on were saying, we're not wasting public health resources on some of the, we're moving public health resources to COVID testing and only letting people in for whom COVID-like symptoms. And then again, certainly most testing is happening in parking lots and tents, whatever else. Primary care has been evolving, but other specialists have really moved. All the case managers I know, most of the health educators I know, all have moved to virtual, including like managing somebody's diabetes. I suspect Bill said we were going to have our dietitians on board. Nutritionists are home counseling their diabetics. I assume a lot of them Zoom and phone, and including some case managers that do healthcare management, medication management, health coaching. All that stuff is pretty quickly, and some of that was virtual, but all that kind of non-primary care, non-healthcare has transitioned pretty quickly. And so part of why that happened was the enabling environment of the government. The first CARES Act, I forgot this happened, but the first CARES relief bill said telehealth is fine outside of rural settings. Like, it had been lined up, rural endocrinology, rural psychiatry, but early on they said, go ahead and use telehealth everywhere, including, this was interesting, including, we don't care if the tools are HIPAA compliant or not. Like, basically it was the government, the Health and Human Services Department, saying we don't have time to get everybody on a HIPAA compliant tool, especially those folks that weren't using telehealth. They're picking up cell phones, they're on Facebook Live, they're doing whatever they can, Skype, some of the HIPAA compliant. We'll talk next time about, as I said, the macro session, we're going to talk about what's HIPAA compliant, more about the details of doing that. The Center for Medicaid Services says, Medicaid, Medicare Services said we're going to pay for telehealth. And then DHHS said we're going to not expect a copay from Medicaid, Medicare, and CHIP participants who are receiving telehealth. So again, to try to get the workforce and patients quickly into a telehealth mode, all of those changes took place in the March 1st relief bill. A few thoughts here about how to do telehealth, and then we're going to go back to questions sort of what's important here is that thinking through which platforms and which clients that again, some of us have kind of blanket gone to a telehealth world, and again, because of necessity. But as we catch our breath and say, who's coming back to work, who's going to see patients live, what safe ways to do that, these kind of questions about thinking about where virtual options work and where they haven't worked, which populations have found telehealth challenging, and what do we do about those challenges? I think there's a chance as we start to shift to the long term. Again, I'm thinking about people in county health departments. I just think a bunch of people are not going back to the office anytime soon. Again, that whole percent of the workforce that doesn't go back are going to go back more slowly than they thought. And so kind of thinking about equipment, staffing, what patients need. One of the concerns, I'm working on a project which presumes everybody, consumers and patients that we're interacting with, are going to have access to high-speed internet. And this is in South Carolina. And we've got people saying, look, you're talking about rural South Carolina. We can't assume that high-speed internet is even an option, much less our consumers can afford that, even those with web-enabled smartphones. So we're just kind of rethinking, like, okay, our strategy was everybody's going to have fast internet. That may not be the case, and what do we do about it? I think it's really important to kind of think about how things change when you go to telehealth. There are studies that suggest that in terms of doing assessment online or by a computer, people can be more honest. Maybe we get more honest history. I think there's a way that I think there's a way that telehealth inhibits connection. I think everybody's doing the best they can at trying to maintain rapport, but I think the screen presents a barrier and makes connection challenging. And so are there patients that you really ought to see? I'm thinking about people who are vulnerable to relapse from their health condition, people who just, people who need more serious support to stay on their diabetes medication, or people that maybe you've got a system set up where you're flagged, someone's testing their sugars, and that gets reported in the system, and you see people whose blood sugars are not doing well, that maybe we say we're going to do a couple clinic appointments a week or a day or whatever makes sense for you, where those most vulnerable patients are brought back in. The reminder about learning technology, unfortunately, because the plane was taking off as we were learning to use it, I think we've all figured the glitches out while we've been working, but best practice is kind of looking at the practicing with the technology, knowing the technology. One thing I still suggest is that people in work groups talk to one another about what they're finding works and doesn't work. That we can now do, the early adopters have figured out how to get into chat with people. I do a lot of webinars, so I'm in chat and break into small groups. What tools the technology has that can help you, and maybe my early adopters can bring some of the old timers along and say, hey, Carla, don't be scared of it. Here's how it works. Here's how I get the video set up in my house. Here's how I make sure the audio works, whatever it is. Again, thinking about backup plans for audio video telehealth. Again, this paper was not in response to COVID-19. These are just best practices from behavioral health, National Behavioral Health System. And I just thought they were so helpful in terms of kind of where we are now. Think about what the appropriate screening tools are. Like, again, who's right for telehealth, who's not, what are our protocols for people with symptoms or not with symptoms, as it relates to school, like what kids are going to come to school in person. How do we triage those people? It's important always to keep documentation in mind and thinking about, sort of how in doing telehealth, we keep and maintain to the best of our ability, assessments, treatment plans, care plans, depending on what language you use. And then ideally an electronic record that other people on the multidisciplinary team would use. Again, if we'd had 6 months, what do you think, Bill, another year? I've noticed we could have got ADPH ready with an electronic medical record that everybody could see and hardware that was functional, where we had a week to get everybody ready. And so I know we're doing patchwork now in some places, but again, that's the gold standard. I think what's also important, again, I'm going to come back to this as a social worker. How is this for you? That again, the reality is, because of the prevalence of COVID, we've got to do this because of the world we live in. We need to do this, but I think that doesn't merit sort of coming in and saying no matter what, we're going to proceed with the telehealth approach. I think asking your patients how that feels, asking them about the strengths and challenges, you can certainly problem solve about understanding the technology. I also think it's really important for them to just validate if they miss us, if they miss coming to the clinic. I think about how many people, go to the health department because they go several times a year because they know people. They've been going a long time. We're better or worse, we're part of some people's families, that they've been with the health department for a long time, and they're missing us, we're missing them. And so just kind of checking about that change in the interpersonal connection. Bill, what do you got? Comment, question, anything I said you want to echo?
I do have a couple of comments and both some questions. Back to the HIPAA. Navigating HIPAA and teleworking has been a real challenge, and it's kind of been hard to work through. And I know you mentioned that some of the HHS rules have been relaxed, and that certainly has been very helpful. But just maintaining patient information, maintaining your reports, those kinds of things, trying to get them back to the office, to get them filed. Access, again, like you said, if we had a year to get access to different programs, that would have been helpful.
Yeah.
I know some of the things that we did here was we would alternate when somebody would come into the office to cut down on the number of people in the office so that they could come in and document and do some of their filing. Any comments on HIPAA though?
Yeah, no, I mean, I think we do what we can. Again, next week, I'm really hoping that we'll drill down even more into these telehealth issues when we do the second part of this. But yeah, it's sort of at the bullet number one for all of us, I think, in terms of our professional ethics is I will maintain patient privacy. Well, if I didn't have a HIPAA compliant tool, but this Tuesday I've got to see this patient for a visit, I'm just going to fire it up. And so, there's some part of how encrypted the program is that I can't do, and who's in the patient background. What you didn't say is patients open up their smartphone or open up their laptop and there's whoever else. I'm talking about their diabetes management or their sexual health or their breastfeeding or whatever. I can't control who's in the room. I can kind of control who's in my room. But yeah, I think for all of us, just trying to figure out as we go, especially for people who didn't have a background in telehealth, who got handed a website and said, here, log in and start doing your job. We were all trying to figure out the best way.
Which brought me to question or comment number 2. We've been doing a lot of phone calls because we're not able to see them in person.
Yeah.
And so, and there's been good Medicaid, Medicare, some of those other insurance companies have said that, please continue to do that. You're doing a great job. However, from a social work side, from an ethical side, we know that there are some things going on just through the communication, through the conversation. And like you said, we don't know who else is in that room, how fearful they may be to answer our questions. from domestic violence, child abuse, sex abuse, some of those questions that we normally are able to go a little further in depth. You don't know who else is in the room, who's listening. And, in our clinics, we're able to take that individual to a private room to talk with them, say, hey, I just need you to hang out here. I need to ask her he or she some private questions or some questions. And so we oftentimes are able to get information and able to then provide care. Thoughts there?
I mean, I think we do what we can, Bill. I mean, I think we say, I'm doing what I can to keep this patient safe and keep their privacy. I'm making sure nobody's overhearing me on my end. I'm coaching my patient as they fire up their phone, or are you in a private place? I really prefer to do this in a private place. Just doing what we can, but like education, like trying to work and keep our kids alive, we're operating in an imperfect world. And so I think, sort of at the end of the day, trying to say, I'm going to do all I can to assure that the confidentiality is maintained and that this is a safe place for my patient. And then at the end of the day, to kind of let go and say, well, given the imperfect world that we're working in, I'm doing the best that I can. But yeah, the issue of safety, I think that starts with, is now a good time? Are you in a place where we can have a private conversation? I think that's kind of a basic. And then who's outside their door? I've had stories of social workers saying, yeah, my patient answers my people with serious mental illness answer the phone in the lobby of McDonald's, and you got to go, no, we cannot talk about your psychiatric condition with you in the McDonald's. So we're going to go, yeah.
With that said, other parts of our clinics have actually seen an uptick in services. Our WIC program, the numbers are actually up. They're enjoying being contacted by phone and not having to come in to the office. And so that's something that we're excited about, and we're going to do a little more research and see what's working, what's not working. I know having talked to the ladies up there in that bureau, how can we make this better? What can we do to really expand on what's going on there? And so there has been some positives.
Absolutely. And I think that's the question. What's working about this? What do our customers like? I use that word customer deliberately. What do our customers like about this? What don't they like? How can we refine what we're doing? And certainly from a business processes perspective, I think it's really important that we say, how can we get back to HIPAA compliant tools? Again, we just all jumped in, but I really think HIPAA compliant phone, HIPAA compliant email, HIPAA compliant synchronous video is essential. Like getting there is essential as quickly as we can, given the economic constraints of doing that.
And with that said, a lot of our workers are coming into the office, but the patients aren't coming into the office. So they're doing telework from their office. And so we do have some things that are still in place, protection there, our systems, our computers, our phones, but you don't know what's going on the other side of that phone. And that's that probably the biggest concern. A couple more things that have come in.
Please.
The second one, or the next one is providing supervision, trying to provide supervision to your social workers that are making those phone calls, maybe from home. And that's a kind of a concern.
Yeah. I mean, and again, I think, it's really important to separate kind of clinical supervision from attendance and HR supervision, different things. I mean, I think from a clinical perspective, I think most of us don't know best practice yet. So it kind of goes back to what we were just talking about, we're all figuring it out, what's worked. I really like the idea of groups coming together and sharing lessons learned, of people who have had more success, sharing those lessons and say, hey, I tried this and it works, and here's what my clients like, and here's what my clients don't like. And so having those conversations, I think, is essential. The nuts and bolts of supervision are still, coaching, observation, feedback. Unfortunately, the ability to do observation isn't there, but asking our workers to understand their, observe their own practice to bring those observations to the supervision meeting, support, coaching. Some of that remains remains there. But the other question, Bill, is sort of if my employees are doing a new task that they weren't trained or didn't have much training on, the people have kind of been thrown into contact tracing. And I, as a supervisor, I don't know a lot about that either. It's sort of, we're finding our own way. The thing about that is where you can, I would rely on those folks who've been doing contact tracing in other programs. And I think specifically of our partners in the STD world, who have, many of those supervisors have been on the front line of knocking on people's doors and doing that work. We got people 20, 30 years of contact tracing that are in any health department. You got some old timers. I just think there are lessons learned from those people we ought to build on. And like I said, if somebody in another social work program got sort of thrust into the role of contact tracing, there's expertise you have within your department that you could tap into and kind of say, what can you tell us? I'm negotiating with somebody about a new contract. I'm going to do some training of contact tracers, and that money comes from the STD world. The people that wrote the course come from that world, because STD contact tracing, I don't know. I know it dates back to the 70s, Bill. I don't know how much further back it goes, but those boys have been doing it a long, and girls, those folks have been doing it a long time.
A couple more comments that have come in have related to continuing education and licensure boards and those kinds of questions, and this virtual training that we're doing now. You mentioned earlier that you don't see a 300, 400, 500 person conference anytime soon. I know here in Alabama, the Board of Social Work Examiners has kind of waived the requirement that you have in-person 10 those 10 CEUs.
Yep.
However, public health, we've gotten approval from our Board of Social Work Examiners that these live conferences, these live trainings that we do, because you have the ability to communicate with the speaker, do count as classroom hours, as we mentioned at the beginning. And certainly those that are taped, you don't have that ability. Do you see, where do you see that going, Jim? Do you have any thoughts?
I see me in this basement on Zoom for a long time, Bill. The same change happened in North Carolina. I'm duly licensed in North Carolina and Georgia. The same thing is there. Everybody said no. I think everybody had a percentage of things you could do on the web or live. In North Carolina, Bill, they've done away with any of it, and they haven't made the distinction of live versus archived. It's just wherever you get your CEUs, come up with the certificate, and we're going to give them to you. Again, I suspect that's going to be refined to maybe something like what y'all have done. But at this point, I just think. So in North Carolina, things broke down. Obviously, people went home in March, and we had a June 30th. We're for some reason, all licensed counselors, all behavioral health, it ends June 30th. So you got a whole bunch of people April, May saying, "Oh my goodness, where am I going to get my CEs?" And the conference has been canceled, or the whatever has been canceled. And the board came out right away and said, "Just get your hours and bring a certificate." So that's where we're moving. I mean, I hope I'm wrong, Bill. I'd love to meet you at the whatever that hotel in Point Clear is. I'd love to be at a big old conference at Point Clear sometime soon, Bill. But I'm not packing my sun lotion just yet. I think it's going to be a while.
Well, Jim, we certainly appreciate what you've been able to do with us. The fact that we've been able to figure out how to do this live and provide those live hours, classroom hours, has been awesome. And so, I look forward to this in the future. We're working with some other groups that here in the building who've been watching and said, "Hey, if Bill can do it, anybody can do it."
Come on, Bill.
We've been the guinea pig. We've been working out some of the kinks, and we've done I think a pretty good job here. Had some good response, and so we'll see where we go from there. But I think you're right that we're going to be in this situation for a little while longer.
I think so. Anyway, Bill, I think we're at time. I just want to do my thanks, and then you can close with your reminders. Thanks. What we haven't said, really importantly, the Alabama Wise Woman Program there at ADPH has provided support for this, and we want to thank Rhonda and the team at Wise Woman for their support. And I always want to thank Bill, you for all your help, and all the people back there in the video room who make this work. And again, those of you who made time today, I know there was 90 minutes where you could do something. I really appreciate you making time for this. Like I said, we're back in a week from Friday to do a second part, and we will keep digging into these issues, more focused on the kind of telehealth, one-on-one micro level challenges that we talked about. So Bill, I'm going to be quiet. You can tell people about their CEUs and how to wrap up. Thanks again, Bill, for all your help.
Jim, thank you so much. This concludes our program today, and I want to thank you, Jim, for being here, and thank you all for watching. As Jim just mentioned, we do have part 2 of this program scheduled for next Friday, August the 14th. Same place, same time. If you've please tell others about it, and so that you can join us there. Also, please remember that you can refer back to the training and the resources at any time on our demand. And with that said, thank you again and have a great day.